Okay. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد الأنبياء والمرسلين. Welcome to SSBMT webinar series. Tonight it is going to be an entertainment night on how I treat AL amyloidosis. We have two eminent speakers, one international and one national. Our international speaker is Professor Paolo Merlini, who is the director of the Center of Research for Research and Treatment of Systemic Amyloidosis. How amazing that we have a Center for Systemic Amyloidosis, and he is the Biotechnology Research Laboratory, Scientific Institute, Policlinico St. Matteo, University of Pavia in Italy. And our next national eminent speaker is Dr. Majid Al-Ahmadi. Dr. Majid is consultant of adult hematology and bone marrow transplant at the Princess Noura Oncology Center at King Abdulaziz Medical City, Western Region. He is also assistant professor at King Saud bin Abdulaziz University Health Sciences in Jeddah. We will start with the first presentation by Professor Merlini on how I treat AL amyloidosis with the new updates that we have been hearing in EHA, ASCO, and soon coming the ASH. Prof. Merlini, the floor is yours, my dear.
Thank you very much for this kind introduction. And I'm very grateful. Can you see my slides? Can you see my slides?
Not yet, Professor.
And continue. I'm very grateful to the organizer of this meeting. Okay.
Now we can see your slides, my dear Professor.
Thank you. Thank you. I'm sorry for the delay. Okay, I would like to thank the organizer for this opportunity to discuss with you tonight the new development in the upfront therapy of this rare disease. These are my disclosures. And amyloidosis is characterized by systemic involvement, except the brain. And the two most frequently involved organs are the heart and the kidney. But the nervous system, both peripheral with peripheral neuropathy and autonomic with hypotension and gastrointestinal problem, is also frequent. Two clinical presentations are not so common, but they are very prototypic. The periorbital purpura and macroglossia. When you see them, it is critical to make the diagnosis immediately, because there are very few diseases that can cause such manifestations. So the symptoms are variable, and they can be with common conditions. So therefore, unfortunately, even nowadays, in most instances, the diagnosis is very late. So why is it important to diagnose the disease earlier? Because if we diagnose cardiac involvement when the patient is still asymptomatic, this patient presents a significant better survival than patients who are treated when the disease is full-blown with overt heart failure. Similarly, for the kidney, if you start treatment when the patient is still asymptomatic, the outcome, the renal survival, is much better. We can nowadays assess the degree of organ involvement using staging system both for the heart and for the kidney. For the heart, we can determine the severity of cardiac involvement using two very common cardiac biomarkers, such as the amino-terminal part of the natriuretic peptide type B, that is a marker of cardiac dysfunction, and the cardiac troponin, which is a marker that is a marker of cardiac damage. So we can stratify the patient in 3 stages, but a European study, a collaborative study, show that patients who present with very high concentration of NT-proBNP above 8,500 have a very poor survival, a matter of few months, and very unfortunately, we have no effective therapies for these patients who represent 15 to 20% of all our patients. For renal involvement, we can stage the patient using 2 simple biomarkers, proteinuria and glomerular filtration rate estimated. And as you can see, patient in stage 1, if they are treated immediately, they never develop end-stage renal failure. We have also determined the criteria for response. So for hematologic response, achieving a complete response, CR, means that we don't have any protein detectable using serum and urine immunofixation and the free light chain assay. As you can see on the right, these patients enjoy a very long survival. So it's possible to change the natural history of the disease if you act in time and very quickly. Very good partial response means achieving the concentration of the DFLC, that means the difference between involved and non-involved free light chain, below 40 milligrams per liter. And this patient achieve also good survival. So it was for that you must reach at least VGPR in order to change significantly the survival of your patient. We determine also the cardiac response according to the reduction in NT-proBNP above 30%. And as you can see on the right, patients achieving a cardiac response have an extremely good survival. With renal response based on reduction of proteinuria, you can see that on the right, there is a significant benefit in terms of kidney survival. Our group went on and together with other groups internationally, it was shown that the degree of hematological response is strictly correlated with the organ response. As you can see, there is a progressive increase in organ response with a progressive improvement in hematological response. But recently, we reported this year that the persistence of minimal residual disease can impair the recovery of the organ dysfunction, and achieving MRD negativity is associated with unprecedented cardiac and renal response. So probably MRD negativity is the best endpoint for therapy. So therapy. Now we can target the critical components of the amyloid cascade. And we can do this using anti-clone therapy, that is by far nowadays the most important therapeutic approach, the most successful therapeutic approach. We can use We can also use antibody targeting the amyloid deposit, as we will see. And light chain stabilizer research is in progress, but we are not clinically available yet. So regarding the anti-clone therapy, what was considered to be very effective is stem cell transplantation. And this is feasible only, unfortunately, in approximately 10% of patients. And we believe that it is worth performing the transplantation if you use full dose melphalan, 200 milligrams per square meter. So patients relatively young, without severe heart involvement, and with good performance status, can preserve renal function, can undergo this procedure. This procedure is very well tolerated, as you see in the upper left panel. The treatment-related mortality is nowadays approximately 2%, and throughout the years, the survival has improved significantly, as you see in the graph in the middle, upper middle. Unfortunately, patients with cardiac amyloidosis do not benefit significantly from this approach. Did not improve throughout the years. So still this is a problem with early mortality. On the bottom part, I reported the outcome reported by the Mayo Clinic investigators. And as you can see, because in this case the survival has improved throughout the years, and achieving a complete response that is achievable in approximately 40% of patients is associated with an excellent survival of 187 months. The treatment of patients who are not eligible for stem cell transplant, that is the majority of patients, of course, the vast majority, is based on bortezomib nowadays. They can achieve deep responses in approximately 50%, in approximately 20 to 40% in patients with advanced cardiac involvement. The median survival of the whole population is nowadays 6 years. And as you can see, unfortunately, there is not much benefit, again, in patients with advanced cardiac involvement, in Mayo stage 3, with high NT-proBNP concentration. Several years ago, we reported that melphalan dexamethasone was a standard of care for patients who are not eligible for stem cell transplantation. We added to this regimen bortezomib, and we show that the addition of bortezomib significantly improved the response rate and translated significant improvement in progression-free survival and overall survival. However, very recently, this year, we reported through an international study that the immunotherapy with an anti-plasma cell CD38 antibody daratumumab combined with cyborg or 12K cyclophosphamide dexamethasone was associated with impressive improvement in complete responses compared to the BCD, as you see here. And as I told you, achieving complete response is of critical importance. Similarly, cardiac response is doubled in patients who are treated with this combination. So this combination, we believe, is even better than stem cell transplantation. And for this reason, this combination has been approved in many countries, and now for daratumumab BCD is considered the standard of care. But the problem is that stage 3B patients they did not benefit throughout many years of treatment based on bortezomib. So we need new remedies, new drugs for this disease. There are several new drugs who are in clinical trials nowadays. Melflufen, that is a modified melphalan that increase significantly the intercellular concentration of melphalan. Several antibodies directed against CD38 combined with drugs also, conjugated with drugs, and also targeting the B-cell maturation antigen. And overall, there are almost 40 trials currently recruiting. About T-cell-based therapy, you know that CAR T-cell therapy is being used now widely in multiple myeloma. And as you see, it was reported very recently at the International Myeloma Workshop, the first case with multiple myeloma and associated renal amyloidosis without heart involvement. This is important for the toxicity of this therapy. The therapy was very well tolerated, as you can see, can produce in 1 month a complete response with MRD negativity that is maintained after 1 year and has produced a complete renal response. So in highly selected patients, this is probably going to be a possible approach for these patients. Recently, it has been reported that we can induce a conditional response in the bone marrow instead of high-dose melphalan using this antibody conjugated with yttrium. And the trial study show that this combination of the antibody combined with yttrium is able to produce excellent bone marrow responses, and it was very well tolerated. So we expect that in the future, this may be another possible way to treat amyloidosis. Targeting the amyloid deposits, it has been reported that in the phase 3 trial, this antibody bictamivir did not produce significant effect in the overall population. However, a post-hoc analysis show that in patients with advanced amyloidosis in stage 4, according to the Mayo stage 4 criteria, enjoyed a longer survival if they were treated with this antibody in association with the standard of care. So the trial now of AL has been planned and will start soon in patients with advanced amyloidosis with this antibody. Another anti-amyloid antibody has been very recently published a few weeks ago in Blood. And in this phase 1A/B study involving 27 patients, this antibody was very well tolerated and improved the organ response in patients who were previously exposed to chemotherapy, but who had still organ dysfunction. The cardiac response observed was particularly interesting because it was present in 8 over 12 patients. So 2 trials now are ongoing in patients with advanced cardiac involvement in order to see if the anti-amyloid antibody is able to recover organ dysfunction in time to rescue this patient. So in conclusion, now we have several opportunities to treat these patients. And as you can see, in the small population eligible for stem cell transplant, we recommend now to infuse the response with data CyBorD for 4 cycles. If the patient achieves a complete response or a very good partial response plus organ response, stem cell transplant can be postponed and the patient can be followed. Otherwise, melphalan 200 can be used and the patient, if achieve a complete response, can just be followed up, or otherwise can use second-line therapy. In patients with myeloma, we recommend to use maintenance for this patient. For the vast majority of patients who are not eligible for stem cell transplant, data CyBorD is certainly the drug of election, the combination of elections. CyBorD, otherwise, if that is not available, or BMTX, but only stem cell transplant is not planned. Stage 3B still represents a problem, but we believe that data can help also these patients. And the combination also of anti-amyloid antibody can further improve the outcome in these difficult patients. So, in conclusion, we have now a really very powerful standard of care that produce unprecedented hematological response and organ responses. New therapies are being developed to target the deposit to accelerate the recovery of organ dysfunction. And new therapy targeting the clone are also under development. We believe that soon we will be able to cure a substantial proportion of these patients. But the most important point is to diagnose them very early. I would like to thank you for your attention.
Thank you very much, Prof. Merlini, for your outstanding presentation. And okay. So there are a couple of questions from the audience. We start Dr. Sami Atallah. He posted the question, 50-year-old patient with only renal failure due to amyloidosis positive Congo red, bone marrow clonal plasma cell lambda type 0.5%, normal protein electrophoresis, and borderline serum free light chain. How you will manage this patient?
Well, if the amyloid confirmed and the typing also confirmed that is lambda light chain amyloid, we can certainly treat this patient with data CyBorD. I believe that he may benefit from this. So I would have no doubt to treat this patient, even if the light chain is borderline. I'm sure that he can recover the organ problem very quickly.
Okay, thank you very much, Prof. Merlini. I have a couple of questions to you. So, AL amyloidosis, always late in diagnosis, and it's a commonly missed diagnosis by many physicians, not hematologists, but other subspecialties. And unfortunately, many patients, their physician, they don't think of the diagnosis except late. And there is a clear chapter in the amyloidosis book about the medico-legal cases. So that's the point, late diagnosis. Now we come to the second question, which is the treatment. And I fully respect your presentation, but with the data you presented, the harmful effect of the late diagnosis of amyloidosis, the worse outcome, why not to move the treatment from the cyborg to more biologic-based monoclonal antibody, more effective therapy, since the patient already harmed by the late diagnosis?
Well, two excellent questions. Thank you for them. Indeed, late diagnosis is a real problem. And the only way to improve it is to do what you're doing now. Improve awareness, make seminars, meetings, and so on, dedicated to amyloidosis. So that is critical. So increasing the awareness is very important, is the most important point. Regarding patient with advanced cardiac involvement instead, that is again due to late diagnosis, of course, but we have noticed that throughout almost 20 years, the percentage of these patients remain the same. So it's a problem that is persistent. I fully agree that we must be very aggressive with these patients. And the benefit of cyborg plus naratumumab is that the treatment is very rapid. You can do it immediately, and the median time to response, top complete response is only 1 month. So this patient is critical to get rid of the light chain as soon as possible. And I believe at the present time, cyborg is the most effective way. We can add antibody against amyloid also. We have to see if the 2 trials which are ongoing will be successful, but I suspect that this will be another way. Of course, if you have availability, you should not discard also heart transplantation in this patient, because cardiac transplantation, in many of them, represent the only way to survive. So if you have, and we have mentioned, and if you have the possibility, transplant these patients and then treat with even stem cell transplantation in order to achieve a complete response. So I fully agree with you that we must be very aggressive, but very careful also not to kill the patient with therapy.
Thank you very much, Prof. Merlini. So there are no further questions in the chat or the QA. I think it's time to move to the first case presentation by you, Prof. Merlini. The floor again is yours.
Okay. Thank you very much. Just a moment. Okay. Can you see it? Try to continue.
Not yet, my dear Prof.
Sorry. Chiudi la presentazione. Fai così di schermo.
So maybe while you are preparing to install your slides, we can do acknowledgement and thank the SSBMT. Yes, we can see your slide, my dear professor. So I was going to say, I would like to thank the SSBMT for their effort to increase awareness of this rare but very important disease. The message tonight, please always think of AL amyloidosis as a cause. Go ahead, Professor.
Okay. Sorry for the mishap.
We can see your slides. Beautiful.
Can you see my slide now?
Yes.
So again, very grateful for this opportunity. I will present now a young man that, these are my disclosures again, a young man that was followed up at our center because he had an MGUS, a GG lambda of low risk, and we follow them during the time. And for the second year control, the hematology was practically the same, so it was very stable. Blood count, etc., was normal. But we do use in our follow-up to follow NT-proBNP and proteinuria in order to detect the alkaline phosphatase, in order to detect the possible involvement by amyloid of the organs. So in this patient, what will you do next? We have actually several possibilities. You can wait and see and wait for the next year to see if things get better or worse. Or you may investigate immediately for amyloidosis in order to reach an early diagnosis. You can refer it to cardiologists because the increase of NT-proBNP indicate a cardiac problem. Or you may decide to stop follow-up because the patient has a low risk and gas and is hematologically stable. So you can vote now, but we don't have a vote system. But in our center, we are very suspicious about amyloid. So we decide to investigate for systemic amyloidosis because, as we have seen before, it is critical to reach an early diagnosis because the amyloid progression is associated with a loss of cardiomyocyte or renal cells, and therefore the damage can be irreversible. So what can we do to improve the diagnosis? Well, as we said before, certainly the increased awareness, but now we have sophisticated way to detect light chains who has a propensity to form amyloid. For instance, if your light chain is glycosylated as kappa, you must think about amyloid. Or if the light chain belongs to these germ light chains. Or now there are even algorithms developed with machine learning that can tell you if the light chain sequence is at risk of developing amyloid. So you can use these parameters in order to increase the surveillance of your patients using the biomarkers that we just see before, NT-proBNP, albuminuria, or alkaline phosphatase. Imaging is also very important. Echocardiography is the mainstay. Cardiomagnetic resonance is very sensitive. You can use scintigraphy with these bone seekers because it is positive in patients with transthyretin amyloidosis, particularly senile cardiac amyloidosis or wild-type transthyretin amyloidosis is the same. We can exploit also the same tracer used for Alzheimer's amyloidosis to detect cardiac involvement. And finally, a new polybasic peptide has been proposed for imaging amyloid. Well, you must show that you have amyloid deposit, and the best way is to perform an abdominal fat or minor salivary gland biopsy bone marrow together with abdominal fat make the sensitivity up to 80%. Otherwise, the involved organs should be biopsied. Typing, we don't rely much on immunohistochemistry because of false positive. We have developed in Pavia this electron microscopy associated with gold label antibodies that is very reliable, but the availability is not very high. Or otherwise, we can use mass spectrometry type. We have it in Pavia. You know, the Mayo Clinic can have this service, and now is considered the kind of gold standard. So if you have a patient with suspicion of amyloidosis, particularly those with cardiac involvement, first of all, you must search for the monoclonal protein using serum and urine immunofixation and light chain. If you have no monoclonal protein, you can perform scintigraphy with the bone seekers. If it is positive, you can do the genetic test on transthyretin and see if it is a transthyretin variant or transthyretin wild type or senile amyloidosis. If you have monoclonal protein, you need a biopsy in order to make the diagnosis. And when if it is positive, you have always to type the amyloid. If the abdominal fat is negative, you can do the organ biopsy. Just remembering that the liver can bleed, so you must use this transjugular way in order to reduce the bleeding risk. So we perform a workup in our patient, and what we found is that the patient was in cardiac stage 2 with minor cardiac involvement. He had still a preserved renal function, and he had a significant bone marrow infiltration with gain 1Q, a fish. So what is the best option for treatment for this patient? So we have several options again here. You can wait until the patient becomes symptomatic. Our patient was completely asymptomatic and was playing squash, so he was very active. You can use norepinephrine as a method of proteotomy, but I will not recommend it in a young patient because it can inhibit the possibility to perform stem cell transplant. Or you can use CyBorD, or the combination of daratumumab and CyBorD. Well, we discuss the options with our patient, and at the end, we decide to treat him with daratumumab and CyBorD. Although also high-dose melphalan could have been a reasonable choice. So we treat this patient with dara-CyBorD, and he achieved a complete response after 4 courses, and after 2 additional courses, he reached immunoresidual disease negativity. What will you do now? Well, again, you can follow up anti-relapse. You can collect the stem cell, can postpone the stem cell to relapse. You can proceed directly to the stem cell transplantation, or you can perform maintenance with DARA every 4 weeks or 2 years. There are evidence that this is beneficial. So again, after discussion with the patient, it was decided to proceed with stem cell collections and postpone stem cell transplant. After 2 years of the end of therapy, the patient is still in complete response, and is still MRD negativity, and he still continue to play squash and to work full time. So we believe that this patient has an excellent outlook for this disease. So now, based on understanding of the mechanism of the disease, that is a spore clone producing an unstable light chains that is toxic and form fibrils, targeting the heart and the kidney above all. We have now several tools to treat this patient. The next one. So we have anti-plasma cell agents that are very active, and we have immunotherapy as well that is used with monoclonal antibodies. We have CAR T cells that start now. We will have in future light chain stabilizer, and we have anti-amyloid antibodies. So we believe that operational cure, that means the patient who is in complete remission with organ response after 10 years, is now a concrete possibility for many of our patients. Thank you for your attention.
Thank you very much, Professor Merlini. Excellent, very interesting case. I have lots of questions, but we will go to the second case, and then we will open the floor for the question and answer. The floor is yours, Dr. Majid, and let's hear your case.
Assalamu alaikum. Good evening, everyone, and I would like to thank the SSBMT for the invitation and Janssen for sponsoring. So, and I want to thank Dr. Bassem for his kind introduction. So this is one of the cases that we had in our center in the last few months. So he's actually, the unique thing about it that he's a young man, which is not very common for plasma cell disorder to see it in that age. So he is actually a 31-year-old gentleman, previously healthy with no medical problems at all. He referred to our center in February 2021 from one of the local hospitals in Saudi. He presented to that local hospital with a 4 months history of cough, hemoptysis, chest pain, dyspnea on exertion, fatigue, significant weight loss of 10 kilogram over that period, and also significant constipation. Before that, so during these 4 months, he actually visited many hospitals, and no confirmed diagnosis was given. The initial thought that this could be some sort of respiratory infection or bronchitis. So multiple courses of antibiotics were given, but no response to all of that. Eventually, he was presented to that local hospital where he was admitted for extensive workup. So as part of his workup done for his respiratory symptoms that I mentioned, which is the cough, hemoptysis, and shortness of breath, he had a CT of the chest, which showed multiple lung nodules with mediastinal lymphadenopathy. So the initial thought this could be infectious. They thought about the possibility of tuberculosis, which is a very wise thinking here. So they sent for a sputum culture and AFP, and well, that was negative. Then they did the bronchoscopy with bronchoalveolar lavage, and all the microbiological workup done was negative, including bacterial culture, fungal culture, and AFP. He had a CT of the abdomen pelvis, which showed significant thickening of the gastric and colonic mucosa. So they did upper endoscopy and colonoscopy, and they found that the mucosa in the stomach and the small intestine was quite friable, easy to bleed. There was no reported masses or anything like that. They were able to take multiple biopsies, and it was sent for one of the pathology labs locally, and it was read as amyloid deposition with a possible underlying malt lymphoma. The procedure was complicated by upper jaw bleeding, requiring him to come back to the hospital for 1 or 2 days of admission and observation. Also, they did a CT-guided biopsy of one of these lung nodules, which also showed the same finding, amyloid deposition. Echocardiogram done there, which showed LVH, so LV hypertrophy with the normal ejection fraction. So the patient was referred to us as a query amyloidosis with possible underlying lymphoma. So on evaluation and his first encounter with us, he was cachectic, chronically ill. His blood pressure was fine as long as all of his other vitals. He had small cervical lymph nodes. The largest was less than 2 centimeters. His skin was normal, no tongue changes. His cardiovascular exam showed normal GVP with no abnormal physical finding cardiac-wise. And also his abdomen showed no organomegaly. Neurologically, there was no evidence of carpal tunnel or any neurological signs. His initial lab work done in our center showed the WBC of 4.2. So basically, the CBC was fine apart from some thrombocytosis. So there was no cytopenias, but there was increase in the platelets and also mild anemia. The LDH was elevated, normal kidney function. Coagulation was fine along with factor 10. He had normal LFTs and normal calcium. His serum protein electrophoresis was negative for any paraprotein as long as the immunofixation showed lambda light chains. His BNP was 265. We don't have the NT-proBNP. Also, we don't have the troponin T, but we have high sensitivity troponin I, which was 214. His quantitative immunoglobulins were all normal. His 24-hour urine was negative for any significant proteinuria, and also his 24-hour urine was negative for Vince-Jones proteins. His serum free light chains were abnormal with kappa 8.2, lambda 153, and as we can see here, the difference in the free light chains were almost 145 here. Kappa lambda ratio is 0.05. His ECG showed low voltage and no other abnormalities. We did on him a PET CT, which did not, because we were concerned about that question of lymphoma. So basically, there was no significant uptake in form of lymphadenopathy. But there was this lung nodule, as we can see here, and also there was uptake in the GI tract, mainly in the colon, and also some reactive uptake in the bone marrow. Cardiac MRI done, which showed diffuse left ventricular wall hypertrophy, most prominent and the interventricular septum with a maximum thickness of 1.7. Ejection fraction was 58%, and the findings on the MRI was quite specific or suggestive for cardiac amyloidosis. Biopsies were taken in the other hospital, was reviewed in our center, which was of a poor quality. There was just only slides, no blocks to do all of the workup. But there was a question of amyloid deposition. There was no evidence of lymphoma infiltration at all. So EGD was repeated in our center, and it showed thickened gastric mucosa, which looked granular, very fragile, easy to bleed, nodular, and with multiple erosions. There was no masses, and I was made sure to discuss this case in prior with the gastroenterologist to, do a full screening for the stomach, for the small intestine, to not to miss any area. In fact, they did also endoscopic ultrasound during the procedure, what's called gastric mapping, to make sure nothing missed in form of a mild lymphoma or anything like that. And there was no evidence of any lymphoma infiltration by the endoscopic ultrasound or by scope during the procedure. Multiple biopsies were taken from the stomach, intestine, and also from the colon. So the pathology from the biopsies were done in our center showed the gastritis with amyloid deposition, no evidence of lymphoma, and all biopsies were taken. Bone marrow biopsy was done, which showed myeloid erythroid ratio of 4:1. There was an increase in the plasma cells of 10 to 12%. So few of them were of abnormal forms. Triphyme biopsy was positive for congruent stain around blood vessels. Fish cytogenetics were normal. So in conclusion, the patient is having a amyloid deposition confirmed by multiple biopsies with evidence of plasma cell dyskergia. He had an increase in the plasma cells to more than 10%, but he did not have any myeloma defining features. So we cannot call it multiple myeloma. It's still AL amyloidosis with cardiac, GI tract, lungs, and bone marrow involvement. So by that time, recently, this case we received this case in February 2021, and in ASH of 2020, the finding of the Andromeda trial was presented, which was quite encouraging in terms of responses for the patients with amyloidosis. You can see here the complete response were detected in 53% in comparison to 18%, comparing daratumumab VCD versus VCD only. So that was the data published in the New England Journal of Medicine, and we, as we heard just now, the results were updated in the EHA, and it showed the continuous improvement in the daratumumab arm in comparison to the VCD arm. So we actually inherited these data, and we used this protocol, the DARA VCD, for this patient. It was the first patient that we used daratumumab upfront, and he received the first cycle in beginning of March 2021. So after the first cycle, there was marked improvement in the patient symptoms. So all of the respiratory symptoms gone completely. Cough, no more cough, no hemoptysis, no short breath. Appetite improved, and he started to gain some weight. Energy also has improved markedly. Biochemically, so the lambda light chain went down to 39 in comparison to 153 at the time of diagnosis. Difference between kappa to lambda were 30, and based on the definition, so he achieved the VGPR after the first cycle of the DARA VCD. Kappa to lambda ratio 0.15. BNP decreased from to 160 in comparison to 265 at diagnosis. After 2 cycles of DARA VCD, he achieved complete hematological response with normal kappa to lambda ratio and difference in free light chains of less than 10. Patient was able to go back to work with some limited hours. So far, patient completed 8 cycles of DARA VCD. So far well-tolerated therapy, no complications at all. He maintained a complete hematological response until now. And we repeated his bone marrow and showed no increase in the plasma cells. He is followed by our cardiologist, and we will have repeated echo next week. He was started in DARA maintenance and planned for 24 cycles as per protocol. Thank you so much. And I'm happy to receive any questions.
Thank you very much, Dr. Majid. It's another interesting case, very interesting age, young, and I have questions for both of you. We'll start with Prof. Merlin. The question, I'm trying to create a table comparing amyloidosis to multiple myeloma. So in myeloma, we have the smoldering or asymptomatic myeloma, but in amyloidosis, watch and wait is not acceptable. Is this true? And the second, in myeloma, there is maintenance, but in amyloidosis, there's treatment with upfront, then transplant, but no maintenance. So how you can compare these two paradigms, Prof. Merlini? And to Dr. Majid, the question, why you did not transplant the patient, Dr. Majid? Thank you.
Okay, so I will start with my responses. So the patient, so question
regarding the first question, why there is no watch and wait in amyloidosis where it is practiced in asymptomatic or smoldering myeloma?
It's an excellent question. And I must say that all questions were excellent here. So the reason is that we know that if we wait until the patient is symptomatic, it's too late. So in amyloidosis, it's so critical to reverse the amyloid damage as soon as possible to the organs. That we must start therapy immediately. The same is true also when the patient relapses. In myeloma, you wait, probably you don't treat according to biochemical relapse. But in amyloid, as soon as the light chain is back, we start immediately the treatment because we know that the light chain is killing your patient. So don't watch and wait. You are absolutely right. Be aggressive. And there's the excellent case presented by Dr. Al-Hamadi show the therapy, response to therapy can be very quick and astonishing in this patient. So you can really change the life of this patient in a matter of few weeks. So start the therapy immediately. Regarding maintenance, this is another excellent question. Well, there are two considerations to be made. First, usually the amyloidosis clone is a small clone, and many of these patients achieve a CR that can last for years. So there is no real proof that maintenance is useful in these patients. A different, now we have the possibility to use maintenance with daratumumab, so is a question mark for the future to see if this, but in our center, for instance, we look for MRD negativity. If a patient is in CR and MRD negative, we don't perform any maintenance. Otherwise, I think that it may be useful. If a patient, as I show in my flow chart, has a myeloma or a substantial bone marrow infiltration, then you should consider maintenance in this patient, of course. But for the last majority of patients with amyloidosis, at present time, we do not have data supporting maintenance. Again, because the value of the clone is different than in myeloma. It's a small clone, it has less mutation, and is less aggressive than in myeloma. So in most of these patients, the clone can be really eradicated.
Excellent. Okay, Dr. Majid, why you did not transplant this patient, your patient, as per standard of care? Upfront transplant is recommended. So,
okay, so standard of care for not everyone, for someone with extensive cardiac involvement with multiple organ involvement, then the mortality of the transplant will be higher. So this patient had a systematic cardiac involvement. At the beginning, his BNP was elevated, and that was associated with poor tolerance for transplant, and it might associate with higher mortality. Having that said, I'm not closing the door completely. So we followed him along. Unfortunately, until now, his BNP has not normalized, which made me reluctant to take him for transplant. Yeah, as I mentioned, the cardiologist will see him. So, you know, the good thing, the beautiful thing about the protocol DARA VCD is not quite myeloablative. So even if I want to collect him now after his cardiac condition has improved, I think still that will be doable. I want to take him for transplant, but you know, we have to balance with the risk, especially cardiac wise. So you know, it is something we want to push for, but we have to be careful in the same time. The other thing, you know, now with the introduction of daratumumab up front, and for Prof. Merlini also to share that with him. So now all the data we have on transplant was with VCD. So with introduction of DARA VCD, do you think that can, you know, decrease the need for transplant in the upfront setting for amyloidosis patient, especially with the excellent outcomes we are getting with DARA VCD?
Dr. Ramadi, let me tell you first that I fully agree with your strategy, because it was a clever strategy to perform transplant in a safer conditions. So I think that you made the right choice. Absolutely so. Now the first choice is DARA cyber D. And the transplant can be used as second line in case you don't achieve a good response. And in Europe, you know that there is a very big study that will be presented at ASH. They show that in Europe, only 6% of patients with amyloidosis can undergo transplant, and 10% can undergo transplant as second-line therapy. So your strategy is the same strategy we use. To use DARA-CyBorD first, keep the patient achieve a very good response. We harvest the stem cells, can keep them there, can't wait to use the transplant as a second line. And I believe that this approach is very effective, is very safe, and it will possibly become the standard of care in the near future. For your patient in particular, Dr. Ramadi, the fact that you can now perform the stem cell transplant in a better condition for the patient is really a benefit for the patient overall. So we believe that, as I show in my flowchart, first-line therapy now is DARA cyber D, also because it's very quick. So the action, as I told you, the response can be seen even after the first infusion of daratumumab. And that is a great benefit in higher amyloidosis, where time is so critical.
Excellent. So I have one question or MCQ question to Prof. Merlini and one question to Dr. Majid. So Professor Merlini, which drug you think changed the history of treatment of AL amyloidosis? So the options are melphalan, proteasome inhibitor, immune modulating drugs, monoclonal antibody, transplant, all of the above. Of the above, I would like to call a friend. So which option you will choose? Which drug that really changed the history of AL amyloidosis? All these options.
Well, it depends on the period you consider, of course. In the 90s, I would say that melphalan, and particularly high-dose melphalan, was a real breakthrough in this disease, but also melphalan. When bortezomib appeared, and it's clear that bortezomib has changed. You have seen that the median survival now is 6 years. And just a few years ago, the median survival was less than 2 years. And in patients to achieve a CR, the survival now is above 10 years. So altogether, I believe that at the present time, daratumumab is another important player. So, and we hope that monoclonal antibodies against amyloid will produce benefit. So we are looking at these trials with much curiosity, but the evidence is not there yet. So, I'm sorry, I've been a little bit ecumenic, but this is the truth. I mean, for each period, each of these drugs mentioned played a key role.
Excellent. And now the question to Dr. Majid. So why you choose daratumumab as maintenance? Why you didn't choose proteasome inhibitor or IMID?
As per the study, I'm following, following the protocol made by the study, so we're just following that. So there, the maintenance is daratumumab, so we're following the same.
Which means you have to bring the patient. So if the patient says, I don't want to come, I want tablet, what you will offer him? I will give you Securia, Abu Omar, okay? So you will give IMID or oral proteasome inhibitor like ixazomib, or you will give him steroid alone, or all of the above, none of the above. You would like to ask Professor Mellini.
Okay, so if I want to choose, it would be none of the above. Velcade might be the second option for maintenance, and there are data on it. Although when you were talking about maintenance, maintenance Velcade is there, but it's not until disease progression as in myeloma. So drug-free period is advised, and even it's better for the patient to give them some drug holidays in between remissions and follow them clinically. In terms of IMID, so lenalidomide, the data about it is not very effective in AL amyloidosis, and also it's poorly tolerated. So it's treated with more of a GI upset and all of that. There are some data on pomalidomide in second or third line. It might be of an effect, but in the upfront setting, I would not recommend pomalidomide. Ixazomib, it's also, there are data on the IRD in the second, in the relapse setting, not in the upfront. So also it's not recommended, or there is no data about using it in the very upfront setting. So as far as I know, in terms of ixazomib. So options would be bortezomib, or now we have the daratumumab. These are the options that I would give for the patient.
Excellent. So would you consider a double transplant, cardiac and bone marrow transplant for your patient, since there is still cardiac affection and no regain of normal cardiac function? He's young, 31. I mean, you expect him to live 900 years, so still there is a long way to go.
Yeah, so his the good thing, his ejection fraction is fine, and even his 6-minute walk test, he did well with that. So that's very encouraging. So I don't think we are at that stages yet, but you know, cardiac transplant versus no cardiac transplant, I think the most important thing is to control his disease, because even if you let's say did a transplant, like kidney transplant, and the disease is not under control, the transplanted kidney might get affected even faster. So the most important thing is to better control the disease. And that's why we use this novel approach, since it gives you a deeper response and faster response, which we achieved in this case. We don't have the MRD testing. I would be very happy if we were able to do an MRD testing on him and to assure that he is MRD negative, because also that will help in defining what to do from here in terms of maintenance therapy or transplant and all of that.
Yeah. My question now to Prof. Merlini. You know, it's frustrating when you send the specimen to the pathologist. If you don't tell them, please look for amyloidosis, they will not do Congo red. And I don't know, in your case, Dr. Majid, you told the hematopathologist that you are suspecting amyloidosis.
Yes. Oh, yes.
Please do Congo. Yes. Otherwise, they don't do it routinely.
Yeah, no, not routinely, you know, we have to specify. And I think that's important because, you know, amyloidosis, part of it is a clinical diagnosis. So, and we have to remind ourselves, all the patients, all the physicians who see plasma cell disorder, to screen the patients for evidence of amyloid deposition clinically and also radiologically sometimes. So that's important to do in our clinical practice.
Yes, I fully agree totally that I don't know for what reason, but pathologists are rather allergic to Congo red. So it's very difficult to get them to perform it, although it is such a simple staining and so on. In Pavia, we have set up a full set of technology that is also immunoelectron microscopy and mass spectrometry. Can we type all patients nowadays because surprises are always present. So typing is critical in this patient.
It's unfortunate that we have wonderful improvement in treatment, but the diagnosis, we are still behind, except the things that you presented, Prof. Merlini. I hope they are available everywhere in the world, that we are really going into further or ahead molecular testing for amyloidosis rather than relying on this Congo red, which is still standard of care in many institutions.
Okay, fully agree.
I think, you know, I love amyloidosis. It's my favorite subject. I had one case when I was in the university. He presented with skin rash and acute kidney injury, and the skin, actually the dermatologist, he presented and they said they have typical skin involvement in amyloidosis, and skin biopsy confirmed amyloidosis treated with Velcade-based therapy. At that time, daratumumab was not yet approved or discovered, maybe. This was 7 years ago. And then he's doing well till now. Yeah.
Great. I can see that you treat amyloidosis very well there. Indeed.
Thank you. Thank you, Prof. Merlini. Thank you, Dr. Majid. Thank you, SSBMT. And thank you, Janssen, for supporting this educational activity for the sake of our patients and for all the healthcare providers.
Thank you.
Thank you so much. Thank you.
Thank you. Please join us next on 27th of November. It will be real-world effectiveness data for multiple myeloma management. The presentation will be given by Dr. Ihab Al-Hamedi, and so we'll see you then. Thank you very much.
Thank you.
Thank you. Bye-bye.
Bye-bye. Bye.